All good.
So you may have heard our technical conversations, but you are all very welcome. And I can just imagine, I can't see you, I can't hear you, but I am imagining your journey here to be with us today. And it's really wonderful to have you all with us. I think the last time I looked, we've got 71. So a very warm welcome to each and every one of you. So this is a collaboration through myself at St. Richard's Hospice and David Bullard, Dr. David Bullard at University of California, San Francisco, their palliative medicine department. And I'll say a little bit more about David in a minute. So we're here to talk about the FLASH technique. The FLASH technique is a new way of healing emotional distress in hospice and palliative care for patients and staff. And this webinar is for hospice and palliative medicine personnel. So again, delighted to have you all with us. So we have Andy Schwab. So Andy Schwab is a specialist palliative care social worker. He recently won an abstract prize and first place for his oral presentation on supporting neurodivergent people in a palliative context. So Andy will be ably managing the chat, and just an invitation to you all to say hello in the chat, to say your name, your role, and where you're from. You probably noticed that David has already started recording, and I can see that folk are raising their hands. I'm not sure how to respond to that, but I'm going to leave that to Andy and Celeste because I don't multitask well. I'd like to introduce David. So David is a volunteer clinical professor at the University of California, San Francisco. He works in the Department of Medicine and Psychiatry and Behavioral Sciences. He's a licensed psychologist with advanced training in EMDR and somatic experiencing. He's been teaching an adaptation of the FLASH technique for 7 years. He is, now what did I want to say? A member of the San Francisco Psychological Association, and he's taught at the University of California, at the San Francisco Zen Center, and at Tibet House in New York. He's also presented at the first annual International FLASH Conference in 2022, and also for the International Society for Traumatic Stress Studies. And in 2023, he was given a Distinguished Contribution to Psychology Award. So when David shared a little bit about himself, he had so many testimonials about his qualities, and I've been delighted to work with him over the last month or so. Just really value his generosity, his patience, his insight, his sense of humor. So I'm really glad to have David join us today. David, would you like to introduce Celeste?
I certainly would. Hello, everybody. We're so excited about this. Celeste Himanek is a counselor and extraordinaire up in Oregon. I'm in San Francisco, and we met a while ago, and we've done a couple of webinars together. She's very trained for the last almost 20 years in trauma-informed therapies, particularly EMDR, and does EMDR intensives at her place in Oregon. And just an outstanding human being, and one who's really taught me that since she's been involved with the FLASH technique for the last 7 years as well, that it's a way to have fun, believe it or not, with trauma therapy. And we'll be talking about some of that later. At the moment, it sounded like the chat was disabled, but now for some people, but people are in there. Okay, people are using the chat.
Yeah, I've sorted it. No worries.
Okay, thank you, Andy.
Thank you, Andy.
Thank you very much, Andy.
And Celeste, you want to show yourself for a moment and say hi?
Good morning and hello. I'm just looking forward to hanging out, answering some questions, and just sharing in the wonderful experience of people learning about FLASH.
Wonderful. Thank you, Celeste.
Oh, you're
and I
welcome.
realise I should say a little bit about myself. So I work at St Richard's Hospice. I'm a counsellor here at the hospice. I've been privileged over the last few years to train in EMDR and internal family systems, and more recently with Flash. And having learnt Flash, I began to use it in the hospice and was just so delighted at how gentle, how joyful, and how effective it is. And I asked a question on the listserv for people who have completed the Flash training with Phil Manfield and Lewis Engel. And I just kind of said, is anyone doing any work in hospice and palliative care with Flash? Because it feels like it has so much to offer. And there was silence. There was a little bit of tumbleweed. And then Phil Manfield very generously put me in touch with David, and here we are. So yeah, happy to be here, happy to be talking about this, and happy to be with very much more experienced Flash therapists, Celeste and David. So thank you both. So we're going to have an opportunity to experience Flash. We'll have some discussion of the experience. We will do our best to stick to time, but let's see how that goes. Though at some point there will be a 5-minute leg stretch. And then in the second hour, we're going to have an additional look at the literature. We're going to explore client experiences. Hopefully there'll be some discussion and some next steps. So we're going to have a little look at how we can be together today, our aims and objectives, and then I'll be handing over to David for direct experience of the Flash technique. And really, we'd really like to thank the Trauma Informed Palliative Care Network. I know that some of the working group are here today, and probably a lot wider section of that community. It's a really rich place. We've had some great speakers, some beautiful sharing in the community. So there will be a link shared in the PowerPoint, and hopefully a link in the chat as well. So the UK Association of Palliative Care Social Workers supports the Trauma Informed Palliative Care Network, and we're also supported by the University of California, San Francisco, their palliative medicine department, the Mary Center for Education and Palliative Care at Mount Zion, which is also part of UCSF. We're also joined by colleagues with Mission Hospice and Home Care, By the Bay Health, and Hope Hospice and Health Services, and of course, St Richard's Hospice. So we'd also like to make a special thanks to the Spiritual Competency Academy, who have really gifted us. I mean, when we look at the number of people here today, it's quite a significant gift. So they've donated free credits for this event, and that just feels like really, really generous contribution to us all being together today. So a special thanks to them. And Dr. David Lukoff, am I saying his name right, David?
Yes, and his wife, when I reached him, and he was in Germany, he's retired now, but he started this, used to be called Spiritual Competency Resource Center, now the Academy, and they do amazing number of CE certifications and credits. And he told me his wife used to work in hospice, and he was glad to offer this for free to all of the people attending live today.
Wonderful. Thank you, David. So in a way, we're a trauma-informed community, or that's what we aspire to be. And we're not outside of humanity. So we will carry our own history, our own burdens with us into this room that might be personal. And it is likely also to be professional, you know, that we're alongside human suffering day by day. So just to remind us some of the principles of trauma-informed care. So we're hoping that this place will feel safe enough. And just to remind you to kind of just trust your own intuition about what feels right for you. All of this work is invitational. So these are offerings, but there's never an expectation to do anything that doesn't feel right for any of you. We aspire to be trustworthy in terms of our experience and our intentions today. Through our small little community for 2 hours, hopefully there will be a sense of supporting each other. And also more broadly, you know, we have this wonderful trauma-informed community on Mighty Networks. So please do join us there, and we can continue to support each other in this really important work. In the second hour, we're hoping this will be the start of a conversation, you know, so we can collaborate and create this together. And, you know, a commitment to, I know, hearing people's voices because it's a webinar context, but hopefully there will be an opportunity to hear people's voices through the Q&A, through the chat. And if people, you know, if it comes up, we can raise their hands. And a kind of recognition of cultural, historical and gender issues, you know, that we're sensitive. Well, I aspire to be sensitive, and I think we all aspire to be sensitive to how power is distributed in society, and a kind of acknowledgement that it's not distributed equally, and opportunities and privilege is not distributed equally. And my sense as part of working in a trauma-informed way is to actively work against the causes of trauma, and that will include oppression, unconscious bias, prejudice, the assumptions we make at individual and organizational levels. So there's something about, you know, holding these principles in mind as we work together. So my sense, and this is why I was excited about Flash, is there's a recent paper that states it is imperative to develop brief evidence-based interventions and approaches to alleviate trauma symptoms in hospice and palliative care settings. And my sense is that Flash could meet that need. So in terms of being together, you know, this is new. I think this is the first conversation that has been had about Flash in a hospice setting. And we're a diverse group of professionals. So we have nurses, counsellors, social workers, physicians, psychologists, psychiatrists, chaplains, hospice and palliative care workers. And you're all so welcome. You know, I really feel that in my heart, that I'm glad that you're here. And oh goodness, we have a total of 190 people registered for our session today. 46 of us are from the UK, 53% from America, one person's from India, so hello to you, and one person's from Spain, hello again. And a third of us have already trained in Flash, and 2/3 are not trained in any trauma-informed therapy. So in terms of how we are together, there is some PowerPoint, but I promise it's not going to be on the screen the whole time. I'm kind of relying on it for structure, but it will come off the screen at points too, so that we can better connect. And I think what we do know is that the power of relationship is often key in our work, not screens. So hopefully we will have enough PowerPoint to give a sense of structure, and we know where we're going, but not too much. And everyone who's registered will receive a copy of these slides, so you can relax in terms of taking notes, unless, you know, it helps you. So if knowing that these slides are coming to you helps you kind of be, then great. And just to highlight, this webinar on its own is not going to qualify anyone as a trauma-informed therapist. And also we do go on, we're talking about Flash. So we don't have any sort of financial ties to the Flash technique as taught by Dr. Philip Manfield. So our aims, our intentions today are to give you all an opportunity to experience the Flash technique, to learn an adaptation of the Flash technique as a self-care strategy, because the work that we do, you know, we are at risk at vicarious secondary trauma, and when that overlaps with burnout, we're at risk of compassion fatigue. So there's also in our work, there is an opportunity for compassion satisfaction, that we know that we're doing a good job, that we know we have the support of our colleagues, and in a way that's the antidote to compassion fatigue, and we're hopeful that Flash technique has a important contribution to make in terms of our self-care. We might want to consider whether we want to add elements of Flash to the restorative function of clinical supervision. I know a number of us are involved in clinical supervision in our work. And to recognise what aspects of Flash would support our patients. And also to consider whether we'd like to take it further with more formal training in Flash technique or other trauma-informed therapies. Yeah, so just touching again on the importance of the relationship. David and I both like this quote. So know all the theories, master all the techniques, but as you touch a human soul, be just another human soul. So I'm going to sort of run through a few considerations for you so that you can make an informed decision about whether to engage in the kind of experience that David's offering us. So the flash technique has a very strong record of not increasing the disturbance of someone experiencing either in a webinar or in person. So that's over 25,000 therapists over the past 7 years, and nobody has reported any disturbance. However, we do suggest that you don't participate if your sense is that it might be harmful to you in any way. Or also if you're uncertain that you can think of a disturbing memory and then set it aside whilst you watch and listen to the webinar. If your sense of yourself is that you don't have good soothing skills, or if you're not sure that you can manage your activation effectively, then, you know, we're asking you not to participate in the flash experience. But of course, those themes, they're important. And, you know, even me asking those questions might be an opportunity for self-reflection and kind of considering where you might go to get the resources and support that you do need. So, yeah. So I guess then it's over to David, and I will stop sharing. There we go.
Okay, thank you, Sheena. Wonderful beginning, and welcome to everyone. Just a couple words to begin with before we do the exercise for context. In the late 90s, since I'm in San Francisco, I was trained in EMDR, which is very powerful and wonderful, useful trauma technique that Francine Shapiro, who was friends of us here in San Francisco, had developed into a whole community. One of the teachers that she had was Phil Manfield, and for 25 years, he has taught internationally, both advanced EMDR and beginning EMDR. About 7 years ago, he was talking, which he always did weekly, with a friend of mine, who's my colleague, Louis Engel, whose office was next to mine for nearly 50 years. We got rid of our offices during COVID. And Louis and I would have lunch every Thursday for 30 years or 40 years. And he said, you know, Phil's been doing something interesting. He's been doing his EMDR, but he said he gets better results when he doesn't even have the person focus on the trauma memory. Now, up to now, every trauma recognized and approved trauma-informed therapy is exposure-based, whether it's cognitive processing therapy or prolonged exposure that Edna Foa developed. And I just spoke last week with a psychologist at Yale who just got back from the Ukraine, where he's his fourth trip, where he's setting up a PTSD clinic in the Ukraine, and he'd been in Israel training people. And he didn't know about this new paradigm that Phil discovered 7 years ago. So I've been along for the ride. We've had many seminars at my home with 20 or 30 UCSF and VA Medical Center researchers and clinicians. And it's been an amazing to see how immediate this works. And I'm really pretty sure it's a neurobiological event, a switch in the brain that allows the person to understand that what they're seeing in their mind's eye is in the past, rather than feeling it as if it's happening now. We'll be talking about this in the research. There's fascinating research from people who are doing very different laboratory work and functional MRI scans. So back to doing this exercise as a group. Phil and Louis have done it at the EMDR International Association meetings with 500 therapists at one time, pre-COVID. And now, of course, everything's being done online. I wish that I had a one-to-one opportunity with each of you right now, but we're going to do it as a group to give you a sample of what this is like. Again, a third of you have done Phil and Louis's 6-hour training, so this may seem kind of elementary to you. but those of you who haven't experienced it, it's actually kind of fun. So take a moment, if you would, and think of a memory that in some way is disturbing to you. And by that, I mean anything that makes you cringe. It can even be a sense of, oh, my sister's mad at me, I'm sure, because I didn't get her birthday card in the mail in time. A feeling of discomfort, a feeling of dread because I had this auto accident and that was 3 years ago, but I can still see it in my mind. Ugh. If I feel it in my body or emotionally, if it's a disturbance, we measure it on something called the subjective units of discomfort scale, or SUDS. And think for a moment if you can come up with a memory like that. If you're lucky and don't have any of those kind of memories, that's okay. Maybe you'd think of something you saw on the television or the telly, is that it? Or at the movies that was disturbing to you. Game of Thrones, perhaps. Many people are very visual in their memory, and I'm not. I'm kind of neurodivergent myself. I just recognized a year ago or so as people that maybe 5% of us listening today have aphantasia and a difficulty to picture in our minds. My son and my daughter both live in San Francisco Bay Area. I can't immediately see their faces, even though I saw my son 2 days ago. It's very interesting on how we all experience the world through our consciousness differently from one another. My son, for example, is almost photographic in recall, in his memory. So back to your disturbing memory, if you can pick one, and 0 to 10 scale, 10 is the worst you can imagine. I don't even want to imagine. And 0 would be, I had that auto accident, but everything's fine. Nobody was hurt and my body's not reacting. And I actually got a car I like even better after that one was totaled. That would be a 0, of course. So think of, if you can, something that's maybe a 4, 5, 6, but it could be 7, 8, or 9, or 10 even. And now that you've figured out a number, doesn't matter if it's hard to figure that out, but forget about it. And I'm going to ask you to have a willing suspension of disbelief, which simply, that's what you do when you go to the theater or you watch a good movie. You let yourself take it in as if it's real. So I'm going to have you do this, which is the butterfly hug. Some people say accurately it's this, but I kind of like it this way. This is perhaps the equivalent of the eye movement in EMDR. And some of you non-trauma informed therapists may have seen the wonderful interview with Prince Harry. I almost called him King Harry, that'd be a mistake, on Oprah, when he talked about his own trauma and his use dealing with an EMDR therapist and how helpful that was to him. So you're doing this. I'm going to ask you to come up in your mind's eye, which is actually your consciousness is your working memory. My working memory is telling me I'm talking to all of you, and I'm sitting on a chair. I'm in my dining room. I'm looking at a computer, and my hands are going like this. Our working memory is limited. But I'd like you now to come up with something you would like to picture or imagine or remember in your mind's eye. Of course, it'll be different for everyone unless you're telepathic. And some of the examples, we call it a positive engaging focus. On your slides, don't worry about taking notes or anything. Just let yourself get into this experience, because everything will be listed on the PowerPoint slides you'll be getting, including the steps what we're going to be taking right now. So visualize it if you can visualize. It could be a place, a beach, particular camping trip or a mountain. But it also could be a person. One 50-year-old fellow said, I'm going to picture my grandmother. When I was 5 years old, she loved me more unconditionally than anybody has ever since. I don't know if that's humorous or sad or somewhere in between, but he wasn't sad when he said it. It could be, you could imagine yourself right now having an activity, a wonderful 75-year-old psychiatrist with a 50-year Zen practice. When he did this exercise in a webinar like this, he later told us, you know, I remembered a marathon I ran 30 years ago. And at mile 18, when you hit the wall, or most people hit the wall and have a terrible struggle, the opposite happened for him, he said. And he just was in a state of grace and was able to finish the race with no body discomfort. And I asked him, how often do you think of that? And he said, I never think of that. I said, well, what's it like to think of it? He said, it's really wonderful. We all have these moments in life that we've had. It's the opposite of trauma memory. So try and come up with something. People I know who have dogs, about most of them say, oh, imagine petting my dog. Could be any moment in your life that you'd like to just take a few minutes to savoring the experience that you have. And every once in a while, I'm going to interrupt, but keep having your own particular memory. And I'm going to just say flash. And when I say that, blink, 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 blink 3 times, 3 or 4 times. Just go blink, blink, blink. If you prefer to have your eyes closed, that's totally okay. Just squint them 3 or 4 times. Now, why are we doing this tapping? Why are we doing this blinking or the squinting? There is some possible neurobiological reason for it. I also think we're just filling up your working memory right now. And it's even okay to have it overloaded. If you do this and you're feeling sad and it's hard for you to come up with something that's positive, there's a lot going on in the world, and I'll say something about that in a moment, but you could even just fill up your working memory by, for example, say out loud for yourself, it won't bother any of us, 347, and then subtract by 17s sequentially. What? Yeah, 347, that's easy. Then it's 330. But after that, it gets hard for me. That's okay. And you don't have to have an accurate number either. That's another way to do this. Other people use music and have people sing along or dance or watch videos. When they work with children, they might have them watch their favorite video game. It's all we're doing is filling up working memory. And flash, blink, blink, blink. Flash, blink, blink, blink. Pause. Take a moment. This is your working memory, and hopefully you've been engaged in whatever you were thinking of. But now, just lightly bring back what I'm going to call your target memory, which was a negative one. Bring it back to your consciousness, and now forget about it, and come back to, we like to call the positive engaging focus because it's more fun. But more accurately, it just needs to be an engaging focus. One friend of mine likes to use swimming in the San Francisco Bay, which she does most mornings. Brr. That wouldn't be a positive focus for me. I'm interrupting you a bit by talking while you're trying to multitask and have your own personal positive focus, because we learned that it increases things to have a conversational element to it with the therapist occasionally talking. But I'm going to give you a chance to have some quiet time right now. So flash, blink, blink, blink. Flash, blink, blink, blink. Flash, blink, blink, blink. Pause. Bring back the target memory for a moment, and I'll forget about it and come back to, it's okay to change if you want to change your positive engaging focus. Also, I had a delightful meeting over Zoom with a friend who is doing this with me. And she had been on a backpacking trip, and I haven't been backpacking for several years. I just realized I'm hitting my 80th year in December, and it's a shock. Anyway, I hope that didn't bring any of you a negative engaging focus, but just keep on doing what you're doing and flash, blink, blink, blink. So my friend gave me a very visual tour, verbally, of course, of her camping trip, including a 10-mile hike into a hot springs. And when you're doing this work, it's a little bit like reminiscing with someone about their life, some of the positive moments. And some of them, when they start telling you about it, are really right there without being told the flash technique or anything. They're really engaged in seeing what they're telling you about. Pause. Bring back the trauma memory or the upsetting memory or the disturbing memory, the target memory, and ask yourself and see whether anything is different at all. We just did about a third of this. We're going to do some more. But just watch and see if is anything for you different visually, if you're a visual person. Is there anything different in emotional or physical or both elements that may have come up that made it disturbing in the first place? This has been taught by Phil and Lewis to Ukrainian speaking and Russian speaking therapists and Israeli therapists. It's been quite reaching a lot of people. 25,000 therapists have been trained in it so far. So let's come back to this. Stick with the same if you'd like to savor that positive engaging focus, or come up with a new one. Flash, blink, blink, blink. Flash, blink, blink, blink. Flash, blink, blink, blink. While you're doing this, I'll tell you another story. The very first meeting I had at my house back in 2017 in November, Phil and Lewis were talking and did a group exercise like this for 25 people who were from the UCSF Medical School and the VA Medical Center. And at the very end of it, number of people talked about the change that they felt. And Phil said, did this not work for anyone? And a friend of mine who's a Buddhist chaplain spoke up, and she's a very kind person. She spoke up and said, didn't work for me. And Phil said, you want to try a little bit more in front of the group here, just you and me? She said, sure. And she did it, and it worked. Flash, blink, blink, blink. Okay. Bring back your target memory. And if you would, just note, where would that number be? If originally it was a 7 or an 8, is it still a 7 or an 8? If so, what makes it a 7 or an 8? Sometimes people say, oh, it's just the same. Except my body's not reacting. Or some people say it seems farther away, visual people, not me. Or some people say I can see it, but it's pixelated or cloudy. I did this once with a friend who had many years before, had a terrible memory that she'd been driving. So let's get back and do a little bit more while I'm talking. And you can do whatever you want right now. Listen to this, but I think it'd probably be more fun to have your own positive, engaging focus. That beautiful time at the beach, or a person you loved who loved you, or just a dear friend that you knew accepted you no matter what. And I was going to tell you about something that just slipped out of my working memory. I think I'm on the older edge of people who are on this call, but I think I'll forget about what I was going to say. And I'll just say, flash, blink, blink, blink. I'm remembering now. So she had a terrible memory, very visual for her, of driving her car in a rainstorm, and it was in the UK at night, raining. And her husband said, in essence, I'm going to divorce you and marry your best friend. That was a terrible memory, of course, for her. And we did this flash one time. And later, when she brought the memory back up, she said, this is very odd. I'm in the car, but it's sort of filled with cotton batting, and I can't even see him. I don't even know that he's there. And he wasn't there in her life anymore. And it was her brain kind of updating things in a very, I think, poetic, metaphorical, visual thing that it brought up to her. Okay, pause. Again, take a look at the memory and see if anything's changed. And we'll, in a little bit, ask if anyone wants to share. They can put it in the Q&A or maybe the chat if you noticed a difference coming down. Let's just do one more set. Grab your own personal, whatever you'd like to have in your mind right now, while I tell you something else that's been helpful to me. This is a painful, terrible time in the world. We all know. Most of you working in a hospice and palliative care have very frontline views of human suffering. For 15 years, I've been blessed to attend an hour meeting with an outpatient, very innovative outpatient palliative care group at UCSF, led by our physician, Mike Rabo, and there are about 25 people. And it's a wonderful group, but I get to hear about the deaths that they experience. It might be a 38-year-old nurse whose 38-year-old patient with 3 children died. There's a lot of suffering in the world. And then we read about it. We know what's going on in places in the world. So I take heart, though, by here's a short story. The Dalai Lama. 1984, he was interviewed. It's okay to feel interrupted, but keep your own thing going. He was telling the journalist with immense grief and sadness in his eyes what had happened to his country when they were invaded, and the destruction of temples, thousands, and the murders and the torture and the imprisonment of people who were simply following him in his footsteps, following his religion and his Buddhist ideas. Immense grief in his eyes. He looked out at a tree, she said, and when he looked back at me, he filled with something else, and he said, life is so very colorful, isn't it? To me, that gives me hope that we can be in the moment despite human suffering. Another Tibetan teacher that I met, Geshe Pema Dorji, put it this way: if you're thinking about things that are problems in your head and you can do something about it, do something about it. If you're thinking about problems in your head and you can't do anything about it immediately, why are you thinking about it? It doesn't do anything. When we think about things privately, we think we're doing something, but unless you're going to take action, it's your choice. Last, along these lines, I want to say, Mr. Rogers, who was a TV character, has said that his mother told him when he was growing up, when you read about bad things and learn about bad things that are happening that humans do to other humans, look for the helpers. And to me, you are all helpers. You wouldn't be here if you weren't involved in helping in a very deep way at a very powerful, special time in people's lives. So I want to thank you all. We'll pause and take a moment and put in, I don't know, either Q&A, probably Q&A would be best. You don't have to say what, well, that may be disabled. Okay, it's not working. But chat, put in chat what number change you might have had. You don't have to say anything about the particular target memory that you had. We'd like to hear. And again, sometimes the discomfort doesn't come down. And we know about that. Sometimes someone has what my colleagues, Phil and Lewis, call blocking beliefs. An example of that would be, let's say my trauma memory is my dad used to hit me with a belt when I was 5 years old. Personally, for real, my father was wonderful, but let's pretend I had that terrible experience. And I might be asked by the therapist, is there anything that would feel bad about not reacting when you have that memory? And I might say, well, yes, it's like letting my dad off the hook. It's like saying whatever he did was okay. And the therapist might gently inquire, well, what do you think about that today? Does it really, your father died 30 years ago. Is it really letting him off the hook? Isn't it really troubling you at the moment? It has nothing to do with him. I like to think and say that events really happen in life, terrible events. If every terrible event that ever happened to us, we remembered it with this kind of immediacy and feeling it in our bodies and emotionally, we'd all be in a fetal position and we'd be in a room and the world would be too uncomfortable to go out, too scary to go out into. I think evolution has given us our nervous system a way to process bad things, but sometimes they stick, and we'll call that a trauma memory. So let's see, Celeste, is there anything in the chat that you feel we should share with everybody and say out loud?
Sure, you're getting a lot of responses. Thank you so very much. And you're getting a lot of reduction. 8 to a 3, 8 to a 3, down 4 points, 7 to a 2, 5 to a 1. And then we also have someone saying, I'm not sure I can give it a number, but I felt a softening and a fading of the target memory. It became more pale and far away and less charged. 6 to a 3, 6 to a 3, 7 to a 2. Again, a little more of a narrative, fading out of the environment, could still recount the details, but like I was not the one going through it. We've got a 0, resolved or buried, just not disturbing anymore. Honestly, target memory now feels like something between less charged and suppressed. 8 to a 5, it felt so good to see that fade away and take more of a back seat. Memories was from decades ago and was my most painful memory. It started as an 8, and when she muscle tested just now, it was a 0. The memory's blurred. And someone else added, in my experience, this result holds over time. Yes, we've seen the results hold. And not only that, you may find tomorrow that it's even reduced, or later this afternoon, right?
Let me say something.
Time to process.
Let me say something about that, because in the very beginning, when Phil and Lewis and I were talking, I said, well, Phil, doesn't this technique, maybe I in my own mind, I think I had a hydraulic model of trauma, which was, it's this stuff, and maybe you do something like flash and it pushes it down. But then if I wake up tomorrow morning, it'll be back, or next week, it'll be back. Phil said, it doesn't seem to ever come back. And over the years of doing this, that seems to certainly be the case. And I think we figured out why. So imagine that you are typing on your computer or typewriter, I guess, if you're old-fashioned, and you misspell a word. There's an error, a spelling error. And then autocorrect corrects it. When you get finished typing what you did, do you ever tell yourself, I better go back and look? Because maybe after autocorrect corrected it, maybe it reverted back to the error. No, I don't think we do. And I would like to ask an existential question. When you have that autocorrect, the misspelled word becomes spelled correctly. Where is the error now? From memory reconsolidation research, we know and understand they talk about perceptual error. I use it a little bit differently than they do. The perceptual error that most of us doing trauma work understand is one that somehow the memory is caught up at the time it was experienced. But now, today, when you remember it, it's experienced as if it's happening now. Researchers at Yale even are telling us that maybe we need a different word for trauma memory. We'll talk about their research in the second hour. Fascinating research. It should be, our brain should recognize that threat or that upset is in the past. World War II is in the past. Attila the Hun is in the past. My father, if he beat me at age 5, when I was 5, I'm now 70, almost 79. It's not salient. I don't have to worry about that. My mind wants to actually be aware of what's the danger now. That's the negativity bias that we all have, which it's good, but it's also good to have a positivity bias. And that's a little bit like taking some time with PEF. Okay, Sheena and Celeste, why don't you jump in with anything you'd like to add at this point from your own experience? And Sheena particularly has been dealing with using this with inpatients, and Celeste has had her own grief experiences this year. That's been difficult, and she's done a lot of all kinds of trauma work and grief work. She knows it from the inside out, like most of us today. I found most people who've gravitated to doing trauma therapy have had their own difficult experiences. I know I really enjoyed 3 years of Peter Levine's somatic experiencing training, because when I was 3 years old to age 11, had 5 surgeries in a hospital, and they only let parents visit 1 hour a day. So we've all had different kinds of trauma. I'm going to let Celeste and Sheena jump in now with some of their examples.
So I could jump in with one of my examples, but also there's some quite rich comments in the chat. And I just wondered whether that there was a particular question about whether when we do flash, whether this is a suppression, it's a sense that the memory is suppressed. And I wonder, with your metaphor of kind of the autocorrect and correcting an error, whether you'd want to speak to that before we kind of take a break. Oh, I think you're muted.
Not often that I get muted. I like to talk too, but Celeste will have some cogent things to say about this. But again, it's a correction. A trauma memory is experienced as if it's happening now. And the PCC, the posterior cingulate cortex, according to the Yale researchers, fires up when it's a trauma memory or a trauma story. It does not fire up if it's a sad story or a neutral autobiographical story. That's the research they published last year. The PCC, what is that involved with? Mostly present moment awareness. There's some other work, Paul Siegel's work, with very brief exposure that we'll talk about in the second hour. But this, the other thing people ask besides suppression, is it suppressing? What about, we'll get into that in the second hour too. Celeste, would you say anything about the permanence of the change?
I find that it sticks. It sticks, and often that reduction over time. If it's not as low as you would like, I'm always looking for a 0, but I'll settle for less when I have to, because sometimes that's just appropriate. And it's nice to see that dissolution of it over time.
Well, we should also say, of course, for those of you who've taken a 6-hour or more of flash training, you're thinking, boy, David, you're missing out on a whole bunch of material. And that's true. And one of them is the idea that there are feeder memories sometimes that happen, or that are there. I'll give you an example. Somebody I knew who came in, he was angry at someone at work. He said, I shouldn't be angry at this guy. I'm leaving work tomorrow. I'm going to a better job. But this guy that I just dislike a lot, in a meeting, he usually, and he did it again today, he talks over me and he dismisses what I say, makes me feel not respected. And I'm so angry at him, but I don't know why, because I'm never going to see him again. He's excuse me. Anyway, called him a name. And I said, okay, well, feel that in your body. He's feeling the anger. And I said, just float back in time. Does anything pop into your head of an earlier time when you may have felt that way? And he said, no. And suddenly he said, oh, wait. Oh, what just happened? Well, when I was in 3rd grade, I had the teacher made me stand up and read in front of the class. And I had dyslexia, and I couldn't read very well, and the teacher laughed and the students laughed. And I said, wow, what was that like? He said, oh, it was terrible. And I developed public speaking anxiety, but it was just terrible. I said, how is that right now to remember it? He said, oh, it's very vivid. I can see the teacher, Mr. Jones. It just was very cruel. And so going back to the earliest memory sometimes is just amazing how it clears things up. I'll tell you one more quick story. My son had been on an airline flight and had been bumpy, and he wanted to try some flash about this and had him feel it. And his main thing is he was seeing himself on the plane. It's going to crash. I'll never see mom and dad again. I'm so stupid. I shouldn't have flown. I know I don't like flying. He just was beating himself up about the fact that he put himself on this plane. Obviously, the plane didn't crash. I had him do how does that feel in your body? Float back in time. Does anything pop into your mind? Honest to God, he's 35 years old. His memory was of being 4 years old at preschool. At the end of school, his mother came to pick him up, and the teacher said, Mike, why don't you stay for our after-school activity? And he said, well, I don't know. I think I want to go home. His mom said, oh, Mike, you can stay. Oh, I don't know, maybe. And the teacher said, you should stay. The other kids would like you to stay. Okay, so he decided to stay. As soon as his mom left, he had a panic attack. And it was wonderful for him to recognize how that's been in the underground. The background is unconscious all this time. Okay. Celeste, anything that occurs to you to say right now, or do you want to read any more messages?
Yeah, a couple more in the chat, which are just so valuable. And someone's saying what they're being left over with is a profound sadness, which
Yes.
feels appropriate about what happened. And then also the discussion about the blocking beliefs was really helpful. The person had been holding on to a target memory through a sense of guilt that they'd be letting the person down if they didn't vividly remember what happened.
Yes.
So being able to let go of that is okay, for sure.
Because that's just going on in that person's mind. So.
Right. Then somebody's saying, is it okay if you think of multiple happy memories? I said, yes, absolutely, because usually one can lead to another and off you go. So that's great. And over here, we've got a good question about what about events that you can't really remember? but you just have this overwhelming sense of terror around things. And, my answer to that is you can go with what you're noticing somatically in your body and start with that, and just process through those parts. And of course, David, what would you like to add to that?
You're muted still.
I was going to say, Sheena might have something to say about that. Could you repeat the question?
Sure. How does this work with memories that are not consciously remembered? No words, no images, just this sense of terror. So I was saying you can start with what you're feeling somatically and go from there. And just what would you like to add to that?
Because there are components, and that'll be in the slide, components to a memory. Visual for many, emotional, somatic, sensory, auditory, and olfactory. There's a very poignant story from a recording, the first annual International Flash Conference. Someone who was trained, who was a psychologist and a soldier, and working with Ukrainian soldiers who were back only for 2 days of leave. And someone had talked about being around burning bodies. I'm sorry to have to say that, but their memory included a smell, an olfactory memory. And they did the flash, and that just disappeared. I've done that with a couple of people where there was a smell memory associated with it, and that disappeared. It's not happening now. They couldn't smell it now. Sheena?
I guess I would bring a kind of internal family systems perspective to it. So kind of drawing on, kind of meeting that part in the body where you're finding it in the body, and letting that part know that it now inhabits an adult body with access to adult words, because it's in my direct experience of nonverbal parts, my own nonverbal parts, it can be really hard to kind of communicate with them except on a somatic level. And I kind of echo what Celeste was describing about, really sort of meeting that somatic activation in the body, and then trusting our system to be able to process in a way that's adaptive. I don't know if that's helpful or not, but I kind of throwing in another perspective, and it gets complicated.
Very helpful. We're getting close to the top of the hour, and maybe a little more discussion, and then a couple-minute break. And then we'll come back to, we have a lot of material, a lot of things to cover in this short period of time. But I'm so excited and so thrilled to have this groundbreaking opportunity with all of you to look at how, especially Sheena's help, how we can incorporate this, whether you're trained as a flash trained therapist or just a therapist, or not a therapist, how you can utilize this in different ways with people that you work with and with yourself. So, Celeste, Celeste does webinars. She has a wonderful podcast called The Intensive EMDR Podcast that she just started, and has a wealth of information. Anything you'd like to say before the break, Celeste?
Sure. It's I just think about the myriad of opportunities that are available to help take down these ugly experiences. And Flash can be so helpful for this. And so I'll just give you an example I just had this past weekend. My first, I'll say that Flash in my mother's in a nursing facility. And one of her difficult memories is the fall that she took that ended her up in this facility. So we've used Flash around the fall, around some of the other concerns that have come up, some pictures that she's had in her head of my stepdad who passed away in February, who died in the same room with her. And then I had my own experience of going to visit her this weekend. And as I was going in, they had a gentleman who unfortunately needed to be taken to the hospital. And he was on a gurney and he was in bad shape. And so I had that snapshot frozen in my head of that gentleman and just his distress and discomfort. And being able to use Flash on that for myself was really, really helpful. So what we've got to do is just remember we've got this tool in our pocket. I have to remind myself of that. And also, it's just really, really useful. So, and we're getting into some questions over in the chat that are actually a perfect segue into more of that expanded Q&A. Because asking for a little more information about how does this work. And I think that when you get around to that, we'll have lots of good questions you can expand on.
I'll try and be quick. The last one I just saw was about operations. Many of us have had childhood surgery, and it was Peter Levine in 2000 or so. I met him at Esalen with Bessel van de Kolk doing a webinar, and he was the first one who let me know, childhood surgeries can be traumatic. And I hadn't even considered it, hadn't even thought of it. And for me, the disturbing part, as I recall it, besides parents not visiting more than 1 hour a day, which my mother was angry about, that she allowed the medical authorities to tell her not to be with her 3-year-old. But the ether that they used was a suffocation experience. And anyway, we can talk about that in the second half. But I have one other very quick one that I did Flash technique in a coffee shop with a friend of mine who's now very involved in palliative medicine and hospice care, a physician, and she was 8 months pregnant. In the coffee shop, it was the only time we could have to get together. She wanted to try this. So I said, sure. There are people walking back and forth, but we did it right there in the coffee shop. And what the disturbing memory she worked on was, as a resident, her first day in the trauma center of San Francisco General Trauma Center, which is a national trauma center. And she said she'd never seen anything like it, with this blood and screaming and stuff like that. And she was working on a patient with her attending physician. It was her first day there. And the patient died, and her attending said, quick, we have to go to the next person. And she said, wait, we can't leave. He just died. We can't leave him. Yes, we got to go. Come on to the next one. And for 6 years, she carried that with her as a form of moral injury, as if she had done something really bad. And I think our study that was published that we'll be talking about was with healthcare providers dealing in COVID times. And there's a lot of moral injury back then for people having to make triage choices and a lot of different things that went with trying to be a helper. The Flash worked brilliantly for her in a coffee shop in about 10 minutes. So, we're just gobsmacked by this. Sheena, do you think we should take a 5-minute break?
Yes, and apologies. There's a participant who needed closed captioning, so I've been typing to try and fix that. But I think there's a resolution and they're going to watch the recording. But yes, if we could take a break, that would be wonderful, and we could come back to maybe looking at that study you were involved in, because that was extraordinary. Yeah.
In about 5 minutes at 10
Wonderful.
after the hour, whichever hour you're on. Morning for us, and for almost half of you, the end of your day. I want to acknowledge that. See you in a few minutes.
See you, folks. Hi, David.
Hi, Sheena.
Hello, everyone.
Let's see. Okay, Sheena, I think you can begin.
Wonderful. So thank you, everyone, and thank you for that rich discussion in the chat. There was so much to take in. So in this next hour, we have a much looser approach to the structure, partly because I think it would be helpful to go back and pick up some of the questions from the chat. There were some really important questions being asked, and I noticed there are questions in chat and in Q&A. So it would be good to come back to that. We can understand a little bit more about what David was doing. So there was a structure in what David was doing with us, what he was offering us, and the direction. So we can look a little bit more detail about that structure. We have some thoughts about the different ways in which we might make use of these ideas. And then perhaps explore, I think that was one of the last questions in the chat, about what is going on here? Like, how is this working? Isn't it extraordinary? And I know David touched on that a little bit from a neurobiological perspective. But also we've got some poetry, some writing, some reference to spiritual practice. And David and I, and I'm sure Celeste too, we can share some examples from our own practice. And then if there's time, some more questions, or actually we might prioritize your questions before we go to any of the other content. So yeah, that's what we're looking at today. So I think we've covered a little bit about our involvement with chat. Sorry, our involvement with Flash. In part, the reason that I'm here is because when I was 24, I lost my lovely partner, Ernie, to cancer, and he was cared for by St. Richard's Hospice. And it was such a profound experience of being met with such compassion before this building was built, actually, that I, in a way, kind of honoring Ernie's legacy and also the care that I was offered, kind of went on to train. So that's kind of what's brought me here. And then I think we've already shared the rest of our story to be here in this room with us. So kind of moving on a little bit. David, did you want to say anything on that before I moved on? I'm just hopefully not rushing too much.
No. Wonderful. I like the interactive part and getting into the chat. A couple quick things. You know, there's nothing new under the sun. But this seems to be not only new, but pretty unknown. The last year's 2023 annual meeting of the International Society for Traumatic Stress Studies, out of 400 presentations, had 0 on the Flash technique. They don't know about it. The year before, they had 1 panel presentation on the Flash technique. That was one that I got involved with 2 friends who were in Jordan, one of whom interviewed women, refugees from Syria, who had lived under ISIS and had been told their stories. And she didn't know about Flash then, but under the nothing new under the sun, maybe. However, quick story, my mother died at 95 in a wonderful place. I was visiting her one time and her nurse came in, and I remember her quite well. This is about 8 years ago. Her nurse was Vivica, and she said, "Oh, David, good to see you. And Mrs. Bullard, good to see you. Mrs. Bullard, let's tell David what we do when you wake up in the middle of the night and you're anxious and you're scared. I come in and I say, 'Oh, Mrs. Bullard, you are scared. Let's do what we do. I'll be seeing you in all the old familiar places.'" And she started singing, Vivica did, and my mom started singing, and then I started singing. And before we were done with it, we were all laughing. And she said, Nurse Vivica said, "Yes, your mother always starts laughing after I And it's only been in recent days preparing for this that I realized that Vivica knew about the flash technique. It's an appreciation for it's really okay to help people move into laughter, to help. It actually is a neurobiological event, is the way I'm thinking about it now.
Wonderful.
At our SMS meeting, one other quick thing, we meet, 25 of us now online, once 1 hour a week, we talk about who's died, we talk about difficult cases, really all of that. And then everyone says an appreciation at the end. And it's like a target memory of all the difficult things that we hear about, and then a positive of all these appreciations. And it's exhilarating. It's a wonderful way to run a meeting. It's the best I've ever been in. Okay.
Thank you, David. So I'm just going to pop back on the screen a little sort of reflection on the different ways we might engage with these ideas. So I'll just get that back up for a second. Yeah. Okay. Is this working?
Yes.
Excellent. Okay. So I think David perhaps has already touched on this, that there are some of us here who are already trained in Flash, and there is just really wanting to highlight such just how much Flash can contribute to people in a hospice setting. So we will have people who are living well with their condition, and that can be challenging. And I can think of a patient who's given permission to share his story, and Flash can really help them. But even at the point where people are, they might be very close to death, but troubled by historical events. In my limited experience, and I know I'm a novice in this, it is helpful even then, and in David's experience with his mother as well. It's wonderful to hear. And then there's the suggestion that those who are not Flash trained might want to get Flash trained. And then for those of us who aren't therapists, using Flash as a form of self-care, you know, that so often we're side by side in the most awful and also the most significant moments of some people's lives, and taking care of ourselves in that. And then just recognizing the power, just simply recognizing the power of listening, that it's almost like celebrating what we so often do naturally, that we can encourage those positive memories or elicit those positive recollections from patients and their families. And also knowing how to refer patients or family to someone who's trained in Flash. So I think, you know, this is an international meeting. Certainly in the UK, that's not straightforward. If someone has a, you know, and I know Flash isn't just for trauma, but if someone does have a trauma history, it can be very difficult to access trauma therapy in a timely way through the NHS. I think locally here, we're looking at maybe a 3-year wait. And our clients, our patients, they don't have time. So if there's an intervention such as Flash that can reduce their suffering, that just feels essential to be talking about and thinking about how we can get Flash out to the people that need it. So here's a little map on the Flash Technique website. So you can see, and you can zoom in and you can find the people that you need to connect with, either for yourself or your clients, your patients. So suffering is not enough. When you receive this PowerPoint, you'll have David's beautiful, oh, why is it going that? Okay, you'll have David's beautiful voice reading that. So suffering is not enough. Life is both dreadful and wonderful. How can I smile when I'm filled with so much sorrow? It is natural. You need to smile to your sorrow because you're more than your sorrow. And that's Thich Nhat Hanh. And then this is a very beautiful poem that I think was shared in the multidisciplinary meeting, David.
Yes, the poet Danny is a palliative care physician and may even be listening right now. Danny, we so appreciated. She took a workshop that is offered through the Mary Center, Poetic Medicine, and she wrote this. I appreciate you all taking your time when you later to read it. I thought it was just really deeply lovely.
It's beautiful. So I'm skipping through some of this. Oop. Yeah, I'm skipping through some of these. So David, did you want to talk more about what we're doing when we are offering the flash technique? Because these next stack of slides, they're really describing what we did in the first hour. Or would it be more helpful to go back to some of those rich questions from the chat? What would be most helpful?
I'd
do you
like to
think?
go back to the chat, but just to say that in the very beginning, Phil, since for 25 years he'd been teaching EMDR internationally, that was his population of people to offer the flash to. And he needed to keep it within the EMDR realm because EMDR is evidence-based. And over time, flash became evidence-based. Phil Manfield had to talk at length with the American Psychological Association people who said, what is this thing? And he'd say, well, we now have 13 articles, or peer-reviewed articles, or now we have 18 peer-reviewed articles. And he had to keep saying, please let me talk to your manager, or he had to go up the ladder to finally, they agreed that it was evidence-based. However, it's not well known. It's still not well known. But in the very beginning, the 96-year-old person who is a retired scientist I did the flash with, and she's in the slides in audio. She died last year at 100, but she wanted to pass along what her experience was. And it's an audio of how I taught it to her one time. She went home and said, that seems simple enough. I could do it myself. So she used it to help her get to sleep because she'd been having sleep problems because some worries. And it's a delightful little audio. But I knew that I'd be teaching it to people at the medical center who were nurses or doctors who didn't see themselves as doing trauma therapy. And also even teaching it to just regular people and having people do it themselves. And the latest is, this will sound crazy, but I'm just thrilled. My 7-year-old and 9-year-old grandchildren, Sylvia and Roman, have learned it and from their mother. And Sylvia said, oh, I use it if I woke up from a bad dream. And I do the blink, she calls it blink flash. So we were invited to give a little presentation to the 20 teachers at their school. And we did that. And Sylvia, the 7-year-old, was teaching her teachers. Well, the principal now has asked her and her brother if they'd be willing, when school resumes next year, to teach it to 300 students. I'm not saying trauma therapy is easy, but I'm saying that this is a technique that can certainly go beyond the confines of licensed therapists. And we've seen that. And I encourage you, even if you've never been in therapy and never been a therapist, I encourage you that there are elements here that you'll be able to utilize, even if it only accentuates or emphasizes for you that any moment you can be present with one of the people you're with who's suffering. Number one, your presence, even if you're just bearing witness, your presence is a positive, engaging focus. I think of even regular talk therapy. What happens? If I'm your patient, you're listening, you're my therapist, I come in, oh, let me tell you what, I had a tough time at work, I had a tough time with my family, I had a tough time, something's going wrong, I'm feeling depressed, I'm feeling anxious, I'm feeling sad. I tell you the story that's in my head, but little by little, I feel heard. And I recognize little by little, oh, I'm telling you this, and you're here, and you care about me. You want the best for me, and you're not judgmental. You're not judging me. You are the positive, engaging focus. And I think that's an element. We know 50% of the variance of the outcome of psychotherapy is the relationship. I also lastly think something neurobiological is going on, and we'll talk about that later too. But what do you think, Sheena? Get back to the chat questions? Or Celeste, any that we should? I'm sorry that we don't have in this meeting, we didn't have the capacity to have others speak with us, but through the chat. Celeste, any that grab you that we should explore?
Sure. The one that was asked in the chat, and that Sheena addressed a little bit about those somatic parts, about when the memory can't be remembered. And then also we had one who,
When people say it can't be remembered, I think they usually mean it can't be, I don't see it, but they feel something. So it's a somatic memory. Yeah.
yes, exactly. And then someone had also asked both in the chat and the Q&A about working with an adult person who was abandoned by birth parents, and still has intense abandonment issues, but the memory is only in her body, right? And so that was addressed over there also. Let's see what else we've got.
To try and respond to that, obviously, in this format and this time we have, we're not able to, take care of people's disturbing memory fully. You just had a taste of it with the flash technique. But I would encourage you to reach out to someone who's flash trained, or contact myself or Celeste or Sheena, and by email, and we'll be glad to talk more with you in terms of where you could get some
Absolutely.
direction.
You got a lot of seriously good questions over here.
Great.
So we've got people who want to hear more about the research, and the role of the practitioner as the client is engaging. And they're noticing, David, that you are telling gentle stories. Is that the recommended approach? It's one of them. There are many, many. We have somebody asking, my training is in music therapy. Is it possible to use music? Absolutely.
Celeste, tell them about that. Tell them about Simply the Best, right?
Oh, sure. It's Simply the Best, but also I use music videos. Another exceptionally good one is Shake It Off with Taylor Swift, because it gives you a visual to look at. You're tapping at the same time. You've got the music going. It is I tend to do really high energy ones, because that's kind of how I am. And I also do a lot of work with kids, but I don't just save the fun for kids, because we need fun. Also, there's a video, Happy by Pharrell Williams. There's all kinds of different people that you can, every time I watch it, I see something new, and I've probably seen it 100 times. And there are just wonderful ways to bring music in. I've also had somebody use a drum while we were doing flash, and the vibrations of that. We have boom whackers, which are long tubes that have different notes to them that you can use, and they also feel the vibration of those things while you're doing flash. So lots and lots of different ways to do that. Here's an excellent couple of questions. And one person saying, is it important to really turn towards the trauma target to get that story fully, feel it, remember it, etc., before doing flash? The answer to that is no. You're trying to activate that memory, but you do not need to open the pit and fall into it, right? It's just the activation can work with that.
It's a almost non-exposure therapy, and that's the paradigm shift. We had 2 UCSF Weil Institute for Neurosciences webinars about this with researchers. It's not well known yet. We had you'll have links to that in the PowerPoint.
Okay. And then another one is, she's saying, my training and education or work are as clergy, pastoral care, spiritual companionship, and mainly listening. what, if anything, is appropriate for me to use with my traumatized hospice patients and traumatized family members. So I'm going to say this works. This works with that. Absolutely.
But it doesn't have to be the way we did it. It doesn't have to be the traditional. You don't have to tell them to get a trauma memory. They're living in trauma. Sheena, how about an example for us where it's not such a formalized flash technique that you're doing?
Are you thinking about my daughter?
No.
Oh, yeah. Well, I guess because I am a trauma therapist, it's less straightforward for me to answer. I mean, it feels like this is really, as you were describing, David, with your grandchildren and teaching teachers to use this as part of kind of self-care for children, that we're reprocessing trauma memories with this gentle, joyful approach. But it's a fine line, isn't it? Because we're not saying that when we finish this webinar today that anyone's going to suddenly be a trauma-informed therapist, but there are not enough trauma-informed therapists to go around. So where do we draw that line? And it feels like it's an ongoing conversation that there's not a simple answer to for today. That I know Blink Flash is an adaptation, but at the same time, what are we offering to people to take away with them? Yeah.
I'd like to go back to my mentor, Vivica, who was the nurse, who simply demonstrated for me her intuitive understanding that it's powerful when someone's upset to help get them to a different place in their minds. I'm not saying that it's easy to implement that, but at the lowest level, if you've been on this workshop, you should leave it with the knowledge that there's something neurobiological. People are exercising positive parts of their brain simply by your being with them, simply by your even asking some questions, perhaps, about, I know this is a difficult time right now. Is there any time in your life that I don't know about that you'd like to share with me? A kind of reminiscing. Dignity Therapy was a book that's listed as one of the references. You can look at those sorts of things, reminiscing that these are positive. And I hope you'll have more of a sense that maybe some exercising of those brain networks, very complex, are really good to people, good for people. Neuroplasticity, what fires together, wires together, it's the opposite of our default, which is usually to get into worry. So encouraging that with people without doing a formal therapy, without doing a formal technique, without even saying the word flash, without having them blink. There are people in the UK that I know who are saying they're getting good results without the bilateral stimulation and without the blinking. We all blink, as Celeste has pointed out to me, we all blink naturally anyway. I think of those things as overloading working memory, but you may be able to experiment with not even doing that with people, with some of the people you're with.
Thank you, David. I know that sorry, Celeste.
Oh, no, go ahead, Sheena.
I know that there was some questions about the research, and I know in particular the research you were involved in with the healthcare providers and the psychotherapists over COVID, and the results of that research. I'm happy to summarize it, but I know you were directly involved, so you might enjoy speaking more.
Well, I'll try a 5-minute research thing. We have so much in the PowerPoint, and we didn't want to. My favorite quote from Maya Angelou, who was a poet and a writer, is that when you talk with people, they'll remember longer how you made them feel than what you said or how you said it. My hope is that you leave this with hope. Wow, something can change for myself, something can change for the people I work with. There's a tool I can learn more about. I can take Phil's 6-hour if I'm a therapist, or I can just be more engaged with the trauma-informed network that Sheila has been on the working group with. But real quick run through. Several years ago, a colleague of mine, a dear friend, George Silberschatz, a psychologist at UCSF, who is also president of the International Society for Psychotherapy Research. I had him at our house with a meeting with a bunch of other people, and he said, you know, it reminds me of some researcher in New York named Paul Siegel. And we looked at Paul Siegel's work. So here's what Paul had, something he calls very brief exposure. Remember now, the current paradigm is you have to bring back the memory and you have to tell the therapist about it, and either with EMDR or prolonged exposure or cognitive process, you have to really stick with it. A lot of people don't like that. A lot of people won't even go to treatment in the VA Medical Center because they know that's what happens in trauma therapy. You have to, and there are issues from childhood or war that people just, it's overwhelming. They don't want to do it. Sheena MacKenzie, one of our researchers, did electronic medical records of VA medical people who'd had diagnosis of PTSD. And this was like several 100,000 medical records she went through. And she found that only 10% were given the approved trauma therapies and they don't even do EMDR for the most part. They do cognitive processing and prolonged exposure, Edna Foe's work. Her research, looking at the real medical records, showed that only 30% got better. If you look at the randomized controlled trials, 84% get better in this technique and that technique. But I personally don't appreciate holding randomized controlled trials as the gold standard when it comes to psychotherapy changes. It's different for pharmaceutical. People can disagree with me on that. That's fine. There are 2 RCTs of the flash technique, one out of Turkey and one out of Holland, and they're showing good results. Compared with EMDR, they had comparable results, but people preferred the flash technique, and you can understand why. Okay, Paul Siegel's work. Imagine this. He got people who are spider phobic. Then they're involved in research. They don't know the research will be about that. They filled out a questionnaire beforehand, so they don't know what they're going to be in for. They're put in functional MRI scans. 1/3 of them are shown a photograph of a tarantula at less than 100 milliseconds, subliminal speed. They didn't consciously recognize it, that they'd seen something, but they had the fMRI seeing what went on in their brain. Another 1/3 were shown the tarantula photo long enough that people said, whoa, that's a tarantula. The 1/3 group were shown a rose that comparable in a way, it's a control group. Later, they had, I thought, a brilliant measurement of, first of all, self-report. Well, how do you feel about spiders now? Because they had a pre-intervention and now post-intervention. And people had a greater diminishment of their spider phobia, greater diminishment of their fear of spiders. And they brought a tarantula into the room and measured how close people could get to it. The people who had not known that they'd even seen the photo of a tarantula when they were in the fMRI had a greater reduction than the people who had been exposed to the spider. So it's the opposite of you need to have exposure. Non-exposure is better, non-conscious exposure. But what went on in the brain? What seemed to be happening was in real life, if you're spider phobic or not, and you see a spider, whoa, your amygdala fires up. That's the fear center. But the dorsolateral prefrontal cortex, which usually lets us, I'll explain that in a minute, that shuts down. We don't have access to this understanding part of our brains. When they looked at the data from the subjects in the fMRI, when they got shown it at subliminal speeds, so they didn't know that consciously, their amygdala fired up. Their amygdala saw it. But the dorsolateral prefrontal cortex, which goes offline, did not go offline. And it allowed this diminishment of fear. Another way to look at that is when they bring a tarantula in a box into the room and they measure how close you get to it, you may have a jolt of your amygdala saying, oh, that's dangerous. But your dorsolateral prefrontal cortex is able to say, but David, it's in a box and it's got a wire cover. It's not going to escape. That part was available to the people who had non-conscious exposure to it. Okay, that's Paul Siegel. He spoke at our 2 webinars at UCSF. He's continuing that research now with veterans with their PTSD. He has a grant for that. Just November 30th is research is Ofer Pearl, P-E-R-L, is the lead author, P-E-R-L 2023 in Neurosciences. It's Nature Neurosciences. And this is all listed in your PowerPoint. They did a very brilliant study with functional MRI, which is they had people write out autobiographical paragraph of their life, a sad story about their life, and a trauma story about their life. They put them in fMRI. They had someone read them each of the stories, and then they saw what went on in the brain. And I talked about this earlier. A part of the brain that they didn't even think is involved in memory, really, but involved more in present moment awareness. I'm aware that maybe I always talk too much, but I'm going to get back to the questions. The PCC, posterior cingulate cortex, fired up when it was a trauma story, but not when it was a sad story. And it made the researchers say, in a way, a trauma memory is not even a memory. It's something else, and it's a present experience. And that's what we're able to clean up quite quickly with the flash technique. So that's enough about research, but there's 20 studies that you'll be able to look at through the PowerPoint. And thank you again, Sheena, for all the work you did in putting that together. Okay, guys.
So we've got 20 minutes left.
Yeah.
And we could go to talking about some patient experience. So I guess from a scientific perspective, the anecdotal stuff.
Great shift. I love it.
Or there still continues to be some great questions in chat. So
let's do that first.
Okay, I'm trying to catch up. I was just answering some questions.
Oh, sorry, Celeste.
We got the music. Can you pair flash with fears that are really vivid but aren't consciously linked to a known trauma? Yes, I also had someone ask, like, how old does the memory have to be for you to work on? It doesn't have to be old. I've worked on things that have just been hours old. So, and then does holding what someone brings, even without going into the detail in a calm, accepting, caring way, shade into Stephen Porges's polyvagal co-regulation theory? Sure, that aspect of that social engagement. I think that's what you're asking. Yeah, there's all of these pieces that come into it, right? Does this help dementia patients? That's an excellent question.
So new in all of this. If you have any opportunity to try it out, it's such a benign thing. It's something you can experiment with. I really encourage people to experiment. That would be such a wonderful population to work with.
Absolutely.
That's what we've got so far.
Thank you so much, Celeste. So, David, would you like to?
Oh my goodness. Yeah? Okay. Got a really good one. I'll toss this in here for you. It just came through. What about with Holocaust survivor hospice patients who don't choose to talk about their trauma, but are so clearly being affected by it?
Yes.
So yeah, the beauty of it is you don't have to talk about this.
In fact, it can be really extreme. Several years ago, I saw someone that I've known over the years, but he only came in once every several years because he was usually to get a new referral to a psychiatrist. I'm a psychologist. I cannot prescribe medication. And he just liked to check in. And I told him about the flash technique. And he said, interesting, but, and I said, and you actually don't even have to tell the therapist what it is, what your trauma memory is. And he said, what? And I said, no, you don't have to say out loud what it is. You know what it is, and it's in your unconscious. Your long-term memory is another kind of way of looking at unconscious. And he said, oh, I did something one time years ago. So terrible, so awful. I feel so ashamed. I can never tell anyone. It was terrible. I can't tell anybody. And I said, well, that's great. You don't have to tell me either. That's okay. Do you want to try this technique anyway? And he said, sure. 2 weeks later, he made another appointment. He came in and he told me what it was. So pause for a moment. Think of someone who has part of his brain, has a compartment, and he puts something in there and he said, don't open this door. Don't ever tell anyone because there's shame and guilt and awfulness. And that was stuck in his brain. It couldn't come out. It was, I'm sure, contributing to he had long depression. And being able to sit, we all know, if you can share something with someone, a therapist, a dear friend, a mentor, a colleague, and you get heard non-judgmentally, we all know that helps us a lot. And so back to that. No, that's the beauty. That's why we're so thrilled about offering this to people, because it's effective and people do not have to risk being re-traumatized.
Thank you, David. Celeste, is there any more that you want to bring?
Or it might be fun to share with our group the anecdotes of, very short, of some experiences. Celeste, you've been doing this as long as I have, about 7 years. So any particular case you want to briefly report?
Well, I guess I'll just toss one out here that isn't exactly applicable to this population because she was only 4, right? But this little one had been referred to me for EMDR, and she had been in a bad car accident with her parents and she had 2 older siblings. So the smash was difficult. It was a big deal. They all got taken to the hospital. Nobody was injured, which was beautiful. But after that, every time she was in the car, she was throwing up. And so we got it down a lot with EMDR and used some different techniques, which are really lovely in storytelling and all of this beautiful stuff. But we couldn't quite clear all of it because some other aspect, there was something hidden in there. And again, she's 4. And this piece is just beautiful. So Mom, we were also working with an interpreter because Mom was not fluent in expressive English, but she understood a lot. And little one was fluid both ways. And so I had just learned about Flash. This really was when I was first learning it. And I said, let's try this thing. And I told the interpreter, I said, if there's something else, if there's something that you'd like to work on, just go ahead and hold that and we'll see how that goes for you. So that's a beautiful example of, I didn't know what she was working on or if she was going to address anything at all. I just tossed the invitation out there for her. And so our positive engaging focus was this flock of ducklings that the little girl and her mom passed on the way on their walk every day. And so that's what she focused on. We did some flash, we had some fun with it. And whatever there was that was stuck for her got cleared up in the process of doing that. Because, we activated the target. Yeah, we had this car accident. There's still something disturbing. Let's not think about that right now. And then we went right into the stuff with the ducklings, and it cleared it for the little one. And it cleared the interpreter's target in such a way that her mind was blown. So yeah, you don't have to do this deep dive. You don't have to do all this work. And the other aspect that I think we have to fight is our own curiosity. So that's a factor, especially if you've been doing a lot of EMDR, as I have, and many have. You're setting it up and you're getting the picture and you're getting the negative cognition, you're getting this, and where do you feel? And we're doing all of this stuff, and we like to know what's going on. We don't have to know what's going on. And so that's also it can be kind of tough to let go of that, but it's also the beauty of it is you don't have to. So
Beautiful story. Something that I think is being talked about more and more is medical trauma. And I referenced my 5 surgeries as a kid. Recently, I had the opportunity to talk with someone who had, quite a while ago, a year and a half ago, he'd been treated for cancer, had gone in for a contrast CT with the injection of the contrast material, had a terrible reaction. They didn't know exactly why, ended up in an ICU for 2 weeks on dialysis, not knowing whether he would ever be able to get off of dialysis. He did recover, but now it was about 6-8 months later, his physician, his palliative care physician, suggested that he talk with me because he had to get another scan, and he was understandably upset about it. So I met with him over Zoom one time at first, and we got right into it. And he said, how can any of this help me? I have to get that scan. I'm scared. I have to get that scan. I said, anybody has scanxiety who's had cancer. Anybody has a certain amount of anxiety. But you're so visual. And he told me how he could see himself in the ICU. He could see what was happening, and feel. I said, that's back there, and that's turbocharging your normal scanxiety. So we did the flash. He was able to go and do this and had a good result in terms of results. One other quick one, really wonderful woman, maybe in her, I don't know how old she is, 35, 40, I don't know. Had a rare form of breast cancer and double mastectomy and 9 surgeries, because although it was rare, it recurred. And she would have another surgery, and then it would recur, and she'd have another surgery. And she handled it really well, but she had been asked to me by a friend, not as a client, but as a friend's friend, could she try the flash with me? And I said, well, what's it like about all of this? And she said, I'm not afraid of another surgery. I'm afraid of the pain, because each time I woke up with really bad pain, and then they gave me a fentanyl shot. Okay, well, yeah, let's do flash on that. We did. And it was just one of these beautiful things to be involved with, to see someone go from a 10 down to a 0. We also talked about how she could instruct her anesthesiologist before the surgery that she wants to have some injection, a painkiller, before she wakes up. That was reassuring to her, but she was able to, instead of visualizing the last time it happened and feeling the pain and seeing everything, it really changed into something else. It changed her positive engaging focus was she'd been camping with friends. She was in the tent. They let her sleep in. The warmth of the sun woke her up, but she woke up to them laughing. People outside her tent were laughing. And it occurred to me, and we talked about it. It's amazing how often I've experienced it, and Celeste and Sheena, where you take the trauma memory, let's say waking up with pain, and then without instruction, a naturally occurring positive engaging focus came up. What was it? Waking up with laughter. And I've seen that several times, and I'm gobsmacked by that. Sheena?
So yeah, I'm aware of time. So I'm going to try and tell you about 2 patients at the hospice.
Great.
One patient I can't speak to in any detail because sadly they died. And I didn't get consent to tell their story. I would love to tell their story. But Flash was incredibly helpful in the final days. So it's really speaking to using Flash in a hospice setting. I've seen it work at the bedside. Yeah.
And doing the full.
Yep. This was a memory that had been with this person for over 60 years, and it was directly impacting on their experience of receiving care in an institutional setting. Not that we're very institutional, but we are an organization. But that's really all I can say about that. But I did get permission from a wonderful gentleman who is living with life-limiting condition. And part of his life-limiting condition was that his heart stopped about 3 years ago, and he had CPR. He wasn't going to live without it. And it was very frightening and painful. And he made a deliberate trip to see me for 1 session face to face, and told me about the Knights Templar, which was just a delight, to share in his special interest. And this was a 10. The memory was a 10. It had been a 10 for 3 years. He had lived in a permanent state of fear and anger for 3 years. He wasn't sleeping. He was recurrently phoning 999 in terror. In America, 911. And we had a lovely conversation about Knights Templar. He blinked, and the next week he was like, oh yeah, no, it's not a thing anymore. It's like he had so moved beyond it, he couldn't even be bothered to talk about it. And he said that what did he say? He says, when I go to bed at night, I don't worry about whether I'll wake up in the morning. I just go to bed. And that was 1 session talking about the Knights Templar. And I explained that I was doing this, and I asked. His words are on the PowerPoint stack as well. So it's just, for me, it feels extraordinary. And there is a quote in the PowerPoint from Phil Manfield. And I'd just love to read it out. I know that we're nearly out of time, but we have an overwhelming amount of trauma in the country right now, and we need to find a way, not necessarily to cure that, but to make that suffering less. And that feels like that's what I was able to offer those 2 patients living with life-limiting condition. And it is wonderful to start this conversation. It feels like it's not the end of the conversation, but it feels very important to be discussing this with so many colleagues internationally, which is just extraordinary. When I asked David to do this, I was like, look, David, I'm not sure we'll have many people, might be maybe 4 or 5 people. And David was so generous. He's like, well, if this makes a difference to those 4 or 5 people, then it's worth doing. And and now look at us. So it's absolutely delightful to have shared time with all of you. I think there's more questions than we have time for, but maybe we could take them onto the Trauma Informed Palliative Care Network, if people are minded to do that. I will put that.
End of the slides, you'll see our emails, so please feel free to reach out. I think we should have a follow-up sometime after people have had an opportunity in hospice and palliative care to see at what level they're able to utilize it. Not being therapists or being therapists. So That would be great. I am so grateful to you, Sheena, and to you, Celeste, both for such beautiful work that you've done with people in your lives. And I want to extend that to everyone on this who's watching, that we're back to Mr. Rogers' mother saying, there's a lot of terrible things going on in the world. Look to the helpers. And I just feel so grateful that we're all doing this, trying to help. Okay.
Thank you, David. Thank you for your time. David's put hours and hours of time into preparing this. So just very grateful for his generosity. Thank you, everyone. And thank you, Celeste.
Oh, thank
Yeah.
you. This has been fun.
Celeste brings fun into this, and that's what a concept. But
Right?
we can all take a moment. Even the Dalai Lama was able to get back to life is so very colorful, isn't it?
Right. And the
Blessings to
concept,
all.
working on your trauma doesn't have to be traumatic.
That's a great way to end. Thank you, everybody. Bye-bye. You'll be getting stuff in the mail, your email about continuing education credits. You have to fill something out, Google Doc. It'll all come to you. All will be revealed. Bye-bye.
Beautiful.
Thanks so much, everyone. Bye-bye.
Thank you, everybody.
Bye.